Hello, welcome to Sonography Radiology Training Channel. This series of videos is about fetal biometry and growth. This is the first video in this video series with title of Fetal Biometry Part 1. What is the outline of this presentation? The first, introduction and definitions, clinical significance of fetal biometry, assignment of gestational age, first trimester dating, and final teaching points. The first, introduction and definitions. Sonographic measurements of fetal structures provide an accurate means of determining the age of a pregnancy, estimating fetal weight, and assessing the normality of a number of fetal body parts. Gestational age is the term most commonly used for specifying the age of a pregnancy. Prior to the advent of sonography, gestational age referred to the time elapsed since the first day of the woman's last menstrual period. This is also termed menstrual age. With the development of means of dating pregnancies that are often more accurate than LMP, the term gestational age is no longer tied to the LMP. Instead, it refers to the time since the estimated conception date plus 2 weeks. Because women typically conceive at or close to 2 weeks after their LMP, gestational age and menstrual age are generally the same, but gestational age is a more accurate measure of the age of the pregnancy than is menstrual age in a woman with regular cycle lengths. Full term is 40 weeks gestational age. The estimated due date or estimated date of confinement is calculated as the date at which the gestational age of a pregnancy will reach to 40 weeks. Another term sometimes used to date pregnancy is conceptional age, defined as the time since the date of conception. In some situations, such as in patients conceiving through assisted reproductive techniques, conceptional age can be determined very accurately. In these cases, gestational age is equally accurate because it's equal to the precisely known conceptional age plus 2 weeks. To avoid different terms for dating pregnancies in ART patients, the term gestational age is the preferred term for dating all pregnancies regardless of the mode of conception. Now, what is the clinical significance of fetal biometry? Accurate dating of pregnancy is extremely important for managing the obstetric patient, as many clinical decisions during pregnancy are dependent on gestational age. In the first trimester, the timing of prenatal testing for fetal chromosomal abnormalities is gestational age dependent. For assessment of some fetal structure, gestational age must be taken into account when distinguishing some normal from abnormal findings. For example, protrusion of intra-abdominal contents into the base of the umbilical cord can be a normal finding prior to 12 weeks gestation, named physiologic bowel herniation, but is abnormal in the second trimester when it represents an omphalocele. In the second trimester, selecting the best time to perform the sonographic fetal survey to assess for anomalies requires knowledge of the gestational age. According to some studies, accurate dating is also important to determine if a fetal structure is abnormal in size or not. For example, if the femur is small for gestational age, concern for Down syndrome or a skeletal dysplasia should be raised. In the third trimester, accurate dating is needed to diagnose and manage preterm labor and to diagnose postterm pregnancies and determine when intervention is required. Accurate assignment of gestational age is also essential for assessing fetal growth because a key method for assessing growth is determining whether the estimated fetal weight is within the normal range for gestational age or abnormally low or abnormally high. How we can do assignment of gestational age? The gestational age of a pregnancy can be assigned based on either clinical factors or sonographic findings. In general, clinical factors such as LMP or uterine size estimation are less accurate than ultrasound for dating pregnancies. Dating based on LMP is fraught with inaccuracies including incorrect recall, irregular menstrual cycles longer or shorter than 28 days, and variable timing of ovulation during the cycle. Dating based on physical examination assessment of uterine size is even less accurate than LMP because the assessment of uterine size is affected by body habitus as well as myomas and other uterine abnormalities. According to many studies, dating by ultrasound, particularly before the third trimester, is generally more accurate than clinical dating by LMP or physical examination. As I told before, one exception in which clinical information is more accurate than ultrasound for dating is in pregnancies conceived by ART. Such pregnancies can be dated very accurately because the exact date of conception is known. Based on that date of conception, gestational age is assigned as the number of weeks since known conception plus 2 weeks. Once gestational age has been assigned by sonography or by clinical information in an ART patient, the pregnancy should not be redated, nor should the estimated due date be changed. This is because the earlier in pregnancy the gestational age is determined, the more accurate the dating of the pregnancy. Selecting the appropriate sonographic method for dating pregnancy depends on how far along the pregnancy is, and therefore dating for each trimester is different. Now, how we can do dating in first trimester? Early in the first trimester, before the embryo is visible, gestational age can be assigned based on transvaginal sonographic findings. The earliest sonographic finding of pregnancy is a small, rounded intrauterine fluid collection in the central portion of the uterus. The fluid collection may or may not demonstrate the intradecidual sign or double sock sign. What is the intradecidual sign? A fluid collection with an echogenic ring located within a markedly thickened decidual on one side of the uterine cavity. This ultrasound image related to proved early intrauterine pregnancy with the intradecidual sign. This sagittal view of the uterus demonstrates an intrauterine fluid collection lying within the echogenic decidual posterior to a thin echogenic line presenting the collapsed uterine cavity, which is named intradecidual sign. What is double sock sign? An intrauterine fluid collection surrounded by two concentric echogenic rings. This image is related to another proof early intrauterine pregnancy. This sagittal view demonstrates an intrauterine fluid collection with an inner echogenic ring directly around the collection and outer ring in the peripheral aspect of the decidual, which this appearance is named the double sock sign. Now, please pay attention to these important points about these signs. The sonographic appearance of early intrauterine pregnancies prior to visualization of a yolk sac or embryo is highly variable. An early gestational sac can have a double sac sign, an intradecidual sign, or no sign, and the sac and or decidual can have rings or no rings. This is an example of proved early intrauterine pregnancy with none of these signs. In this sagittal view of the uterus, there is an intrauterine fluid collection with a suggestion of inner echogenic ring around at least part of it, but neither a second echogenic ring nor the uterine cavity or intradecidual sign are present, and therefore categorize the case as showing neither of these signs. But here, incidentally, we can see a small amount of fluid in the cul-de-sac. Another important point for these signs, it's common for a gestational sac to appear as a non-specific intrauterine fluid collection without either of these signs. The sonographic finding of a round or oval intrauterine fluid collection in a woman with a positive pregnancy test is likely to present a gestational sac, regardless of whether it demonstrates these signs or not. Is there any differential diagnosis for an intrauterine fluid collection on sonography? A number of terms such as pseudogestational sac, decidual cast, and decidual cyst have been used for intrauterine collections that prove not to be gestational sacs. First, pseudogestational sac. This image is related to proved case of ectopic pregnancy. The uterus at first glance may appear to have a gestational sac. This is not a gestational sac, but simply fluid within the uterine cavity called pseudosac or pseudogestational sac. There is free fluid in pouch of Douglas, which is both coagulated and uncoagulated. Another example of proved ectopic pregnancy, which we can see a pseudosac in the uterine cavity which contains low-level echoes. Another example of proved ectopic pregnancy with pseudogestational sac, which the uterus is full of fluid. The pseudogestational sac is surrounded by a single echogenic ring and is irregular in outline. There is no fetal pole or yolk sac present. Another example we can see here, intrauterine fluid collection with low-level echoes and incomplete echogenic ring. The uterine cavity scanning right through the pelvis also shows free fluid in pouch of Douglas. Some is coagulated and some is not. But with more attention, we can see an obvious ectopic pregnancy in right adenix of the patient. Another differential diagnosis for intrauterine fluid collection is decidual cast. This image from an old paper about 3 decades ago. This transverse and longitudinal scan showing a central ovate-shaped collection of echoes and an adnexal mass in a patient with left ectopic pregnancy. These signs previously named decidual cast, but nowadays is less commonly used. And the final differential diagnosis is decidual cyst. This sagittal and coronal endovaginal sonogram obtained in a patient aged 28 years in whom an ectopic pregnancy was subsequently proved. A small decidual cyst is identified, and the cyst was the only positive finding. Another example, endovaginal sonogram in the sagittal plane obtained in a patient aged 32 years with 36-day-long amenorrhea, and a positive result of a pregnancy test demonstrated 2 decidual cysts that did not abut the endometrial canal. No other positive findings of ectopic pregnancy were seen, but follow-up endovaginal sonogram obtained 4 days later show a right tubal ring with low resistance peritrophoblastic follow, which a right ectopic pregnancy was detected at laparotomy. And the final and most important point about double Sachs sign and intradecidual sign. Despite the possibility of ectopic pregnancy in these cases, because intrauterine pregnancies occur approximately about 50-fold more frequently than ectopic pregnancies, treatment that would damage an intrauterine pregnancy like methotrexate should be avoided unless a viable pregnancy is definitely excluded via follow-up beta HCG values or sonograms. When ultrasound demonstrates an intrauterine fluid collection with no visible yolk sac or embryo, the pregnancy can be accurately assigned a gestational age. When the fluid collection contains a yolk sac but no embryo, the pregnancy can be accurately assigned a gestational age of 5.5 weeks. The presence of a small embryo less than 2 mm in size with the embryonic heartbeat visible adjacent to the yolk sac can be accurately dated on 6 weeks gestation. According to many studies, the accuracy of these early sonographic milestones for dating pregnancy is about plus or minus half of a week. An alternate method for dating early pregnancy is to measure the mean sac diameter of the gestational sac. This is done by averaging sagittal, coronal, and anteroposterior measurements of fluid components of the gestational sac and assigning gestational age based on published tables or formulas. Dating by mean sac diameter very early in the pregnancy has similar accuracy to the dating sonographic milestones, means with accuracy of plus or minus half of a week. However, once the embryo is large enough to measure, dating based on the size of the embryo is more accurate than using the mean sac diameter. From the time the embryo is visible until the end of the first trimester, dating is based on the length of embryo or fetus measured from the top of the head to the bottom of the rump, named crump-rump length. Gestational age is assigned based on CRL by using published formulas or tables. According to many studies, dating by CRL is more accurate in the early first trimester when accuracy is plus or minus half of a week than toward the end of the first trimester when accuracy approaches 1 week. Care must be taken to measure the CRL correctly, particularly toward the end of the first trimester. The fetus should be in neutral position, neither hyperextended nor hyperflexed. In this hyperflexed fetus, the CRL is about 30 mm, equal to 9 weeks and 6 days. But after less than 1 minute, the fetus exists from the hyperflexed position and the CRL reaches to 33 mm, equal to 10 weeks and 2 days. And the last point, that the chin of the fetus must tucked against the chest. The calipers should be placed at the top of the fetal head and the bottom of the rump, making sure not to include the yolk sac or lower extremities in the measurement. When dating a pregnancy during the first trimester, sonography is more accurate than LMP. However, it's acceptable to use LMP to date a pregnancy if the LMP is certain and the difference between the gestational age by LMP and gestational age by first trimester sonography is less than 7 days. Now, please pay attention to these final teaching points. Although conceptional age is equally accurate in assisted reproductive technique patients, but to avoid using different terms for dating pregnancies in ART patients, the term gestational age is the preferred term for dating all pregnancies, regardless of the mode of conception. Accurate assignment of gestational age is extremely important for managing the obstetric patient, as many clinical decisions during pregnancy are dependent on gestational age. Dating by ultrasound, particularly before the third trimester, is generally more accurate than clinical dating by LMP or physical examination. The earlier in pregnancy the gestational age is determined, the more accurate the dating of the pregnancy. And the most important point, despite the possibility of ectopic pregnancy in cases with pseudogestational sac, decidual cast, and decidual cyst, because intrauterine pregnancies occur approximately about 50-fold more frequently than ectopic pregnancies, treatment that would damage an intrauterine pregnancy like methotrexate should be avoided unless a viable pregnancy is definitely excluded via follow-up beta HCG values or sonograms. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.